We're going to talk about something that'll hopefully get you excited or engaged. We're going to talk about Section 35 or involuntary treatment for substance use disorder, sort of current state, and how we can maybe shift it some. I am Deb Goldfarb. I'm a clinical social worker. I'm the director of population behavioral health at Boston Medical Center. I oversee some programs related to high-risk behavioral health populations, as well as work with the Graken Center for Addiction on criminalization of addiction work, policy work. My interest in Section 35 actually first came about probably around like 2014, 2015. I was actually a clinician at MCI Framingham, the women's prison in Massachusetts. So it was my first job out of grad school. Very eye-opening. They, at the time, women still went to Framingham on Section 35s. I had no addiction training in my social work school, no formal addiction training. I had personal experience that I brought to the table. I remember I would be working in the sort of admissions or intake overnight on the 3 to 11 shift. People come in from court, and women would arrive in quite rough shape, and their family members thought they were sending them to treatment, and there they were in the state prison. So that really sort of opened my eyes to how these systems not only, don't do what they intend, but actually really can cause quite a bit of harm. And through that, that led to various work in the criminal legal system, including at a criminal defense clinic, and then coming back to BMC a few years later to do this work. So. All right, what are we going to do today? We're going to talk about the current state. We're going to talk about some of the potential harms of inviting carceral frame rapes into SUD treatment. Really sort of excited about some of the conversations yesterday and earlier today that's already sort of set the stage for thinking about sort of non-punitive approaches to care and where we really need to sort of hold ourselves responsible and make some changes. And then we're going to talk about some resources to advocate against some harmful approaches. I think a lot of these presentations have the super traditional 5 slides about the war on drugs. Very important. You probably have all seen those a million times. But I do think it's important to set the stage, because that's the reality of the systems we're working within. And so for me, when I think of involuntary treatment or carceral systems within addiction treatment, these are the things I feel like we are fighting against. So of course, there's the stigma and bias, which leads to us sort of relying on removing folks from the community that we deem as different or dangerous, right? Instead of, using that as a form of social control instead of addressing the root causes. And then of course, not just the prison industrial complex, but the medical industrial complex, and our forces of capitalism that push us to profit off people's illnesses. And then, of course, the PIC profiting off people's detention. And I think those are quite apparent in the way Section 35s have been in Massachusetts over the last few years. How did we get here? No surprise, we know substance use is associated with increased risk or morbidity and mortality, which leads public health folks to want to reduce the health burdens. That's normal. We do this all the time, right? We require motorcycle helmets in Massachusetts, or, seat belts. But, when I think when we sort of add in those factors we just talked about, so stigma, bias, racism, we come with this kind of challenging outcome that ends up, oppressing certain populations more than others. And so I think we've also seen in Massachusetts in the last few years a lot of political pressures. I'll call out mass and caste because that's the world I live in, but I know it's happening in other communities, to sort of hide away our social problems by incarcerating or forcing treatment on folks. This is a helpful graphic for me, at least, just to sort of tie all these things together, right? So our prison population, the war on drugs, the lack of a treatment infrastructure, And more than the lack of treatment infrastructure, I would say the lack of like person-centered or culturally responsive treatment, I think, is probably the bigger issue. And then, of course, the labeling and relabeling of addiction as criminal behavior. And so this work requires us to sort of unlabel, which is really challenging. So what does involuntary substance use treatment look like nationally? A call out to the Health and Justice Lab. They have a lot of cool data you can play with. And it, more states are starting to create involuntary commitment law. So I sort of say we're moving in the wrong direction, it seems. Isn't that surprising given what's happening sort of at the federal level? So about 38 states right now have some mechanism for involuntary treatment of substance use. And the issue is there's little to no data across the board, but definitely on outcomes like overdose rates post-release or successful treatment completion. I thought it'd be helpful just to look a little bit more closely at New England. I know we have some other folks in the room. Every state deals with this a little bit differently. In Massachusetts, we separate our psychiatric commitments and our substance use commitments, right? We have section 12s and then we have section 35s. Some states put them together. As we can see sort of, and I'm not experts in these other states, but Maine puts them together. New Hampshire has no specific involuntary commitment for substance use disorder. And Vermont, they just have really outdated language altogether. But they also include them together. So what about in Massachusetts? So it's called Section 35 because it's Section 35 of the Mass General Laws. Here we can sort of see the wording, quote, likelihood of serious harm as a result of his or her alcohol or substance use. Highly subjective, clearly. And that folks have to go to, quote, an approved facility, which is we're really going to spend a lot of our time talking about what exactly those facilities are. The other sort of concerning thing we'll talk about as well is that it allows a, quote, qualified agent to carry this out. We'll talk sort of about like who is actually qualified to be doing this in our state. And so that's just probably some of you have seen these before. This is the form you fill out to pursue a Section 35. I'm actually going to skip and go back because I realized, okay, this is a better. So this is a very simplified version of the Section 35 process. One of the issues we'll talk about too is it's not exactly the same in every jurisdiction, and that's part of the issue. But it starts with some perceived risk in the community. So someone's perceiving this could be a family member, a physician, or a police officer. The risk can be acute or chronic. That's not defined in the law. You could be engaged in outpatient care or not. You could know the person in outpatient care or not. It could be in the ED, it could be inpatient. So that looks wildly different in how we define risk. Then we have the folks that can complete the petition. So MDs can. Family members, I think it's defined as close blood relatives or spouse. That is really, it's interpreted differently at every single court. And I think that's one of sort of the downsides of it. Cops, police officers can Section 35, court officials, and then an individual's guardian. So if we're sort of thinking of like clinical ability to calculate risk, I would say MDs are probably the only people on there that maybe are qualified to be doing so, yet most Section 35s are done by family members or police. So a petition it goes in front of a judge, there's a warrant issued. Again, I'm simplifying this all. The individuals might be picked up on that warrant, right, if the police carry out that warrant. And folks are treated as if they committed a crime. So they are arrested, they're handcuffed as if they're arrested, they're put in a police cruiser, and they are brought to court and put in a holding cell within the criminal court system. This is a really high risk period for a lot of folks, because you are spending hours in transport and hours in a cell where you largely do not have access to any medical care, right? And if you think by essence of you're at risk because of your substance use, like you're probably starting to detox at this point. You will then have a court hearing. I think a lot of folks don't know you are assigned an attorney, you're assigned a public defender. And I think, though, as we know, attorneys have a wide range of knowledge of substance use disorders, and a wide range of knowledge of Section 35s. So when I worked in a public defense clinic, I had attorneys who were very well versed in substance use treatment and did a great job advocating for folks. And then I had other attorneys who was their first time ever touching a Section 35. So that varies wildly. There is then an evaluation by a court clinician, which you do have the right to refuse. You also have the right to have your lawyer present for that, which a lot of folks don't know. There is then some testimony by the petitioner, and an exchange in the courtroom. And then ultimately the judge is making a decision. Again, sort of a non-qualified, non-medical professional making a decision about your healthcare. At that point, if the judge rules that he doesn't want to uphold the section, he doesn't think you meet the criteria, you're just let go from court. You now may have been sitting in court for 8 hours, and you may be across town, don't know where you are. So we've had lots of situations of folks that are just sort of released, and frantically calling their social worker, asking, you know, how to get back to wherever they were before. Most cases that make it to the point of a court hearing, though, about 90%, that the section's carried out. So if you make it to this point, the cops find you and you get in front of a judge, you're pretty much going to get sectioned. A lot of us who have worked in the courts know that a lot of judges, you know, have personal feelings about substance use, like we all do, that have, you know, stigma and biases. They might have lived experience. And, you know, the joke always used to be is who was ever on bench that day, I could tell you, regardless of the client, if the person was going to be sectioned or not, just based on what judge it was. So unfortunately, I think it's not necessarily a very clinically informed process. So if the section's upheld, then the individual will be placed in an approved facility. For men, which we're going to concentrate on quite a bit, they can still go to correctional institutions, so institutions run by the DOC for matters of Section 35 treatment. We'll talk about how that ended for women in 2016, and we'll talk through some of the facilities, but that's sort of the most concerning, biggest reform I think folks have been trying to pass. You know, placement into the facility, it's supposed to be based on the client's history, bed availability, and so forth. For instance, if you're a Department of Mental Health client, you're supposed to automatically go to the newer DMH-run facility called RAP in Taunton. We have found, though, that there's quite a lot of bias from judges. So even if there's beds open at non-DOC facilities, they are still sending certain individuals to the DOC facilities, which is really not supposed to be happening. Okay, I'm going to go back now. Okay. So what's the history of Section 35s? It really came about in 1970. It was really seen as sort of a mechanism for family members, right? And if you go to any Section 35 legislative hearings today, the voices of family members who have a desperation to help their loved ones who are impacted by substance use disorders are the loudest voices in the room, and they're powerful. They have really powerful testimony. And so a lot of us who have been fighting for reform, you know, often feel it's often, you know, the family member's voice that is really pushing legislators to not affect change. And that is, of course, very, very complicated. You know, it came about during a time, you know, pre-opioid epidemic. It was really sort of seen for folks with severe alcohol use disorder. I'm just calling out here again, like the Section 12 process is different. I wouldn't say it's great. I will say it is at least dealt with in a healthcare setting, not the court. So some of us who think of reform think of maybe that's a better approach to have it mimic at least the Section 12 system. And of course, psychiatric commitments predate Section 35s by many hundreds of years. Here we see as well, most sections are upheld by judges once they get in front of them in court. And we are sectioning about 5,000 people a year. We'll look at the amount of petitions that go in is quite a bit higher. And that's the difference in the numbers is a lot of warrants are issued, but they can't find the person, which can be really frustrating for family members going through all those steps and then not being able to find the loved one. The law says commitment for up to 90 days. Data shows this is generally much less time. It's more like 3 weeks, I think is the average. These pictures here are within one of the correctional Section 35 facilities. It's a jail. That's what it is. It is functioning inside of a jail. I also just want to call out sort of the importance of good press and media, and Deborah Becker from WBUR, who's a reporter, has done a fantastic job these past few years covering Section 35s. And so I think, we have some good allies in that sense. And she's really unearthed a lot of what's happening. All right, this is the volume of Section 35s from 2013 to 2024. This is all public data on the DPH website, so encourage folks to, go play around on it, and you can choose by county and stuff like that. We Section 35 very few juveniles. There's just not many beds, actually. But, that's the small red bit on top. These are case filings, right? So this is the number of petitions that are handed into a court, not the number of matters that are heard, which is a little bit more like the 5,000. So we see a little bit of a peak, but in general, it's been pretty stable. This breaks it down a little bit more, sort of showing that, there is a discrepancy in the number of petitions filed versus how many are actually evaluated by the court clinician, but then shows most evaluated by a court clinician do in fact get sectioned. Here's some demographic data. Anyone that works with folks who are experiencing houselessness knows that most data around homelessness is underreported. So I think it is probably much higher than 22%. My guess is it's mostly from self-reported address, and a lot of people give mailing addresses or family members' addresses. We can also see the race here, which what we know about racism within the criminal court system, we might expect white rates to be lower. But I actually think there's somewhat of a inverse racism happening here, and that a lot of us sort of working in this space assume that patients of color are more likely to be sent to jail on overlapping criminal matters, not given the opportunity to go to Section 35 treatment. So that's what we think that's about. And also that white family members might be more likely to petition a court and involve the criminal legal system in their kids' lives or family members' lives. And then I think it's not up here, but it's about 63% are males in terms of folks that are Section 35. This is, fiscal year to date. So we're about on par with what we've been other years. You can play with that data online by county. I was just calling out this one difference I saw, that You know, Hampden County is about 1/3 the size of Suffolk County, yet they have a higher rate of Section 35s. I have some thoughts, I'm sure others do too as well. I think one is probably treatment access in these counties. Hampden County sheriffs also run their own Section 35 facility. And so I think there's probably you know, a little bit of a flavor in town to fill those beds. And this is, I think, or what I believe, where we see sort of the prison industrial complex really sort of pushing in there, this desire to fill up empty jails in order to keep those facilities running. It's probably no surprise to anyone that these environments, particularly the correctional environments, are non-therapeutic. For anyone that's ever worked in corrections, you know that security will always take precedent over care or treatment. You know, when I was a clinician in Framingham, my treatment absolutely relied on the participation and cooperation of correctional officers. And so simple things like the COs didn't want to open a cell door for me because they were on break, or they were upset that I had written them up the week prior for talking to a client inappropriately. They would just say, too bad, we're not letting you see your client today. So that's really what's happening behind the walls in some of these places that really make it challenging for even quality clinicians to provide ethical care behind the wall. Of course, access to healthcare, so I'm talking about other kinds of medical care, is constitutionally mandated, but the quality of that care lags far behind. In a lot of ways, it's because the medical and psychiatric contracts for care are private for-profit companies. And so it's incentivized for them to cut corners. We have seen improvements. It's not all bad. We have seen improvements in MAT and MOUD in these facilities. That is for sure. So it has expanded. It's offered in all of the Section 35 facilities. Unsurprising, correctional environments can exacerbate the sort of those co-occurring mental illness or medical diagnoses we see in many of our patients. We've seen high-risk elopements from facilities. You know, again, folks are there against their will. There's a feeling of desperation. And then, of course, like in other correctional facilities, we saw pretty large COVID-19 outbreaks in these facilities as well. Any treatment happening in correctional environments, whether it's Section 35 or otherwise, there's also some additional things to consider that really make it hard to provide good care. So just a matter of folks have very little autonomy over their healthcare choices. There's very limited confidential space for treatment. In the DOC, the joke is always there's no such thing as HIPAA, and that's pretty much true. You have a lack of access to like all these non-clinical interventions that support people's recovery. Yeah, I'm talking about durable medical equipment and stuff like that, but just little things, you know, ability to write or journal. Depending on what facility you're in, you might not have access to materials like that. Poor access to specialty care. And then in the Section 35 facilities run in correctional institutions, they're following a lot of the sort of suicide or risk protocols that happen in other facilities, which are extremely punitive. And so a simplified version of that is simply, if you are suicidal, the one tool that a clinician has is to take away all your belongings and to put you in what they call a turtle suit, sort of a smock, an anti-suicide material smock, and put you in a cell with nothing in it. Expect you to get better. That seems pretty wild. So it kind of goes against everything I think we know of sort of healing and recovery. And this is happening within the correctional Section 35 facilities. So when we have sort of this combination of factors, we're creating really unsafe environments. And there are many people who have died within Section 35 facilities. There are people who have died after, and we'll talk about the high rate of overdose post-release. But this is about Aisha Johnson, who died in Suffolk County House of Corrections in 2021. There were articles written about her, and her family came and joined a few of us at the State House to advocate around Section 35 reform. But Aisha was Section 35 by, I believe, her father, who thought that he was going to get her some treatment for her alcohol use disorder. He was feeling quite desperate. She was a mom. I think he wanted the best. And it was suggested to him that he can go to court and get her sent to treatment. Aisha was detoxing in court and during transport. It was quite obvious. She was vomiting in court and did not receive medical care. And there wasn't a treatment bed open for a female at that time. So she was brought to the House of Corrections to wait, and she died in book-in. So of course there are other stories, and but that's an avoidable death and one that shouldn't have happened. So some of these I already talked about. There's a big sort of lack of standardization in the court process from city to city. This is really hard because you don't exactly know what to expect in your own community unless you do a deep dive, right? Not to mention if you work in multiple communities. Hearings also only occur Monday through Friday, 9 to 5 during court hours. I don't know of a single substance use crisis that has ever occurred during 9 to 5 business hours. So this means you're in the emergency department, it's 4 p.m. on a Friday, and whomever thinks it's a good idea to Section 35 you, good luck. You have to wait till Monday to have your crisis. So it's just not a good solution logistically, not to mention the sort of ethical piece of it. Of course, we see that their judges have discretion where they send you, regardless of where there's open beds. Every police department handles Section 35s and actually Section 12s very differently. Even the process of how the warrants get sent to the police department varies from court to court. So some police departments will actively go out and look for people on civil warrants. Others will not. Clearly, I'm not the biggest fan of Section 35s, so I'm not too concerned about police not finding people. But this is really frustrating for family members and medical providers who put in a lot of effort to try to get someone treatment, and then it doesn't happen. It's also just a huge waste of resources. One of the biggest issues that I do think is a place for fairly easy reform, and this is something that I talk with folks at BSAS about, is that the sheriff's departments manage the transports. Those are really sort of high-risk transports, and there's, of course, no medical providers as part of the transport process. It's in the same vehicle they transport folks from prison to court. And so those are really high-risk periods, and they'll often take people from court that belong to a bunch of different counties and make a bunch of different drop-offs. And so you might be in that transport van for hours on end, handcuffed, rolling around, and then maybe you're detoxing or sick or have other medical needs. So if we just sort of used ambulances or some sort of medical transport, I think it would make the process safer and probably more person-centered. I've also found that a lot of Section 35 facilities are unable to manage acute medical needs. So we had a patient at BMC. I sometimes get, looped into these situations in which someone's thinking of Section 35ing someone, and come to find out there's no Section 35 facility that will take someone on dialysis. And so we came up with all sorts of crazy workarounds to try and make it happen, and we couldn't. No 35 facilities can provide 24-hour oxygen. No Section 35 facilities will take folks if you can't, quote, manage your ABLs. And so this just ends up, again, not meeting the need of our patient population, and making it really frustrating, for folks that try to section folks who maybe fall in those categories. I have also found that even with Department of Mental Health running a Section 35 facility now, that has had good outcomes. I mean, there are people that I've known who've gone through that program who say it is better than the other programs. They can't handle acute psychiatric needs. We had a patient at BMC who got Section 35 by police, went to the DMH RAT program, got Section 12 from there to an inpatient psych facility. Then the inpatient psych facility, Section 35 her back there. I mean, you can just sort of see how wild this is. With a really big systemic message that, you know, we can't help you, you know, we can't meet all your needs in the same place. And so to me, that's a big issue. These are all the programs in the state that accept folks on Section 35s. You'll see Framingham is still up there. It's because they'll still take folks, if you are a female who's Section 35 and you have bail, like you have a criminal matter where there's bail set, they will send you to Framingham still. So they call those dual, right? Because you have a criminal matter and a civil commitment. And then, you know, we see in the bottom some of these facilities are sort of alternatives or designated programs if other ones aren't accepting. You can see the bed count there too. So of course, some facilities are much larger than others. And then we see the correctional institution, so MASAC, which is at an old DOC facility in Plymouth. And then Stony Brook, which is the Hampden County Sheriff's Department runs that one. Those are our largest facilities, 160 and 152 men. You know, I can't talk about this without talking about other ways in which we have coercive treatment. It's not just Section 35s. So of course, Section 12s are used for dually diagnosed patients. I could talk for another hour about drug courts and specialty courts and some of the challenges that folks face in terms of coercive treatment within those systems. And then of course, we see endless types of stipulations put on folks by probation and parole that are coercing treatment under the threat of incarceration. And as we know, outside of those sort of formalities, people with substance use disorders receive all sorts of informal coercion from all sorts of systems to be in treatment. Providers, family, licensing boards, employers. And so if you're committed to sort of anti-carceral SUD care, it means really evaluating what other coercive or punitive policies may have within your own system. And I really appreciate the folks sort of yesterday talking about changing some of those within the OTP system. All right, what's the evidence? You know, in general, there's not good data. You can't really generalize it state by state because the laws are so different, the systems are so different. There's also a huge issue with data transparency. It's gotten a little bit better. But in general, it doesn't work, is essentially what this is saying, right? You know, you have a very high risk of overdose when you release. One Boston hospital, it's not BMC, but found that 100% of their patients they Section 35 returned to use within 1 year and had at least one emergency department visit within that year. And over 3/4 had a medical admission within the following year. So anything that had such a big failure rate, we would never do in any other context. So sort of why are we continuously relying on it? A 2018 study found that the average time of relapse following commitment was 72 days, but 34% relapse on the same day of their release. But I don't actually need the data to know this is wrong. So there are a lot of harms that happen in this system. I've seen them. You probably have talked to patients that have experienced it. If you haven't, talked to them about their experiences. You know, I just think the potential harms, intended or otherwise, just outweigh any gains we can get from this system, especially in Massachusetts, where we actually have like pretty good voluntary treatment options. Like we have a lot. It doesn't recognize that like folks with substance use disorders are competent and can make their own decisions. It also provides a lot of moral injury to providers, right? These are really tough decisions to make and to sit in. American Psychiatric Association doesn't like this, or most people don't support this. And the thing that I sort of really feel is strong is that I challenge anything that allows the criminal justice system to have power over people's personal choices, right? You would never tolerate probation choosing where you got cancer treatment. That would be wild. So why are we allowing this for other medical diagnoses? And then of course, which I think is probably front of mind for a lot of providers, is if you Section 35 someone, you might completely ruin your rapport with them and they might lose trust in the healthcare system. Another Boston hospital, I actually put it up here, had done a study that said like, I don't know, 75% or almost 100% of folks that they Section 35 out of their ED didn't return. And in my mind, I was like, well, they didn't return because you forced them into treatment, not necessarily because they recovered, right? And that's, so I think some of those studies out there can be a little bit misleading. All right, there's been a lot of calls for reform. Unfortunately, most of them have gone unheard, given that men are still being sent to correctional institutions. So in 2018, there was a Section 35 commission established. There were healthcare professionals on it. Maybe there's people in the room that were on this commission. The commission said we should change our practices, that we should stop sending men to correctional institutions, and yet we still are. All right, the last few minutes we're gonna talk about advocacy. So when I think of advocacy, I sort of think of the intersection of all these places, which is litigation, lawsuits, legislation, so policy change, and then education, which is things like this. So there was a piece of successful litigation in 2016. Shout out to Prisoner Legal Services, who have been amazing advocates for folks being Section 35. They filed a lawsuit, you know, against the state for women who are being incarcerated on Section 35s at Framingham. In response, they created law in which they stopped this practice. So basically the threat of a lawsuit created policy change. However, this left a huge gender inequity because men were still being sent to 35 facilities. So this is ongoing litigation led by Prisoner Legal Services that was filed in 2019 and is still ongoing. So the plaintiffs are men who have been sent to MASAM, which is the DOC civil commitment facility. And they're making all sorts of legal claims. One is gender discrimination. So this is no longer happening to women, why men? That it's a violation of the Americans with Disabilities Act, because people with substance use disorders have a disability, and that it violates the 14th Amendment. And so this is still ongoing, essentially what the last bullet point is saying. Yeah. All right, legislation. So there have been efforts to pass this piece of legislation for many years. And I know there's been, you know, folks in the room who have been out there also fighting for this. So it would require for men, as well as, of course, continued for women, to be in healthcare facilities that are approved by DPH or DMH and not in those few correctional facilities. You know, the Senators Cindy Friedman and Rep. Ruth Balzer have been huge champions of this work. Yet we haven't gotten there quite yet. So the House adopted an amended version of this policy that was set within their large omnibus substance use bill. And it requires that MASAC just closes by 2026. And that those beds would need to be moved to non-carceral settings run by DPH or DMH. However, the House and Senate are still negotiating on a final version of the omnibus substance use bill. So the call to action is writing to the folks in this conference committee, asking for them to include this language in the omnibus bill. Again, I mean, it's not transforming the system, right? It's just sort of like taking out the most harmful part of it. You know, and I think there's lots of reasons why this change hasn't happened. I think there is some concern about treatment availability, what happens when we take away these beds. And I think the other concern is that MASAC and Hampden County Sheriff's Department don't want to lose the contract. They don't want to cut correctional officers. They don't want their budget cut. And so they push really hard and they advocate and mobilize against these bills. The other piece, education. So we've been working on this document, I'm embarrassed to say, for many years now, and hopefully it'll be out soon, but it's almost done. But it's essentially like a sort of best practices guideline or resource. It's intended both for staff, providers, and family members. My work specific to BMC started, I don't know, maybe like 4 or 5 years ago, when I had a patient who was in our emergency department. And I called down to the ED. I thought the guy was going to be section 12 and go to inpatient psych. And I called down to the psych attending, and or maybe it was a resident, but anyways, they said they were going to section 35 him. And I said, that's concerning. He has open court cases. You know, he could go to a DOC facility. And this doctor had absolutely no idea what a section 35 was. And did not know the process, did not know the person was going to come and get handcuffed by police at the hospital. And so it just made me realize, like, there's a huge lack of education on this system, and believing that if people have the right information, they're going to make the right choice. You know, that like physicians don't want to cause harm to folks. So if they know what the system is like, they're probably going to make the right choice. Within this document, there's a bunch of different things, resources, alternatives to section 35, and so forth. We also sort of we made this decision tree, you know, and it's really to sort of have folks sit down if a section 35 is on the table. I'm in a lot of like MASAM CAS system meetings where, like, on the daily, someone is like, oh, section 35, that person. And so having some guidelines or best practices. So of course you should try to have the entire care team present. And then there's a lot of factors to consider, and they're not all clinical, right? So depending on their gender, they might go to a DOC facility. You should probably take that as part of your decision-making process. I will say trans and non-binary individuals can choose a facility that aligns with their gender. I will say that's like what the policy is. Does that happen in practice? Unsure. You probably need to do some additional advocacy for those patients. So to know that if folks have open court cases, like open warrants, anytime you go in front of the judge, you have a risk of incarceration. So if you're section 35ing someone who has an open warrant on a criminal matter, there's a higher risk or a potential that they will be sent to a correctional institution. So take that into consideration. You could just ask the person, they know if they have open cases for the most part. Ask people if they've, you know, been through a section 35 process before and has it been helpful. On a rare occasion, someone will say it has and they want to go back on a rare occasion. And then, you know, does the person have a history of trauma? Like, how will this traumatic experience impact them? And then I want to think about risk. I do some work in the emergency department, and there it's sort of like, did this person walk into the ED by themselves? Or do they come in by an ambulance because EMS saw them down? That's a big difference to me. If you walked into the ED or help seeking, I think it's inappropriate to section 35 you. if you're found by EMS down in the street multiple times in a week, okay, maybe this is on the table. Maybe we need to start about mitigating that risk. Would it fracture trust? Of course, other things like, are you imminent risk of overdosing? Are you a fall risk? Things like, are you unsheltered versus housed? That impacts risk. And then sort of social things, right? Would Section 35 in you negatively impact aspects of your life? Will you lose your job? Will you lose your housing? Will you not be able to keep up with your caretaking responsibilities? And then ask yourself, after all of that, sort of do you have a plan as a provider, supporter, helper, to ensure the person can be transitioned out of the Section 35 safely, right? Their release is really high risk period. And so if you're an emergency department doctor who's never going to see this person again, do you have a plan to make sure that that person's, going to be followed up with by your health system? All right, final slide. It's funny because the other BMC team, we did not look at each other's slides. They also, I guess we're aligned across our institution, which is a good thing. So essentially, that was all about reform or mitigating risk or making some changes. I'm an abolitionist. An abolitionist would say, you can't reform this system. It's harmful and oppressive. I will say it's a continuum. There's space for everyone in this sort of fight. So, incarceration of any kind harms communities and individuals. I am worried about the investment in dollars in these systems, because anytime you put money in a system, you're taking money away from prevention and other community resources. And that we should be centering the voices of what people want. And then, of course, I think efforts may be better focused on decriminalization of all substances. Yeah, I think I'm right at time.